It's my privilege today to talk to you about the challenges and opportunities for the management of metastatic prostate cancer by radioimmunotherapy. My name is Barry Allen and I'm from Sydney, Australia, and I've been working in this exciting multidisciplinary field for the past 2 decades. Topics to be considered are the challenges of metastatic prostate cancer, targeted therapy, comparison of in vitro and in vivo studies for targeting vectors labelled with alpha or beta emitting radioisotopes, clinical imaging and therapy of the various radioimmunoconjugates for prostate cancer. Our objective is to find the best radioimmunoconjugates for the management of metastatic prostate cancer. Prostate cancer is perhaps the most over-treated cancer, yet its incidence is such that it is still a leading cause of death in men. But primary cancer is treated by many different approaches. But if the cancer cells have escaped, then prognosis is poor. Androgen deprivation therapy works quite well for most cases, but has side effects and leads to the repopulation of hormone-insensitive cells with a median survival of about 18 months. However, it does achieve a minimum residual disease state that begs for a new therapy to provide further management of the disease. Targeted therapy, TAT, is such a therapy. We are indeed fortunate to now have 3 targeting vectors for prostate cancer, 2 of which have been tested in clinical trial. We also have 3 radioisotopes in preclinical and clinical trial use. These are lutetium-177, a low-energy beta emitter, bismuth-213, a high-energy alpha emitter, and actinium-225, a very high-energy alpha emitter, which emits 4 alphas. We now look at the evidence for preclinical efficacy of targeted alpha or beta immunotherapy. We'll first look at the results of extensive in vitro experiments, comparing alpha with beta radiation for external beams and for internal targeting. We will also compare the cytotoxicity of targeted alphas using the vectors C595 and J591 against MUC1 and PSMA antigens. Comparative targeted therapy is also investigated by Monte Carlo calculations. The comparison here is between external beams and photons and alphas irradiating 2 cell lines. The survival curves are fitted with a linear quadratic model. The high linear energy transfer, LET radiation, gives a linear curve on the log plot, below LET radiation, a shoulder curve. The relative biological effect, that's the RBE equals the gamma dose over the alpha days, is 5 for 1% survival. Survival of melanoma cells after incubation in different activities of a 9.2.27 monoclonal antibody labelled with bismuth-213 or terbium-152, and the RBE for 37% survival is 120 after correction for branching ratios. This amazing result was our first study in this field and set the stage for ongoing grant funding and publications in TAT. Shown here is the survival curve for the prostate cancer cells incubated with a specific bismuth-213J591 conjugate and a non-specific bismuth-213 conjugate. This result clearly demonstrates that the alphas are only cytotoxic to cancer cells when they are targeted and attached to those cells. Monte Carlo calculations use random event probabilities to build up an outcome spectrum. In this case, it's the mean nuclear-specific energy in grey on the y-axis for different radioisotopes on the x-axis. Specific energy is shown for targeted single-cell hits by multiple alpha emissions, single alpha emissions, and beta emissions from the designated radioisotopes on the surface of a cell. Radium-223 and actinium-225 have 4 times the specific energy of a single alpha, actinium and bismuth. The beta emitters are 2 orders of magnitude lower for bismuth-213 and 3 orders below actinium-225. The long half-life of actinium-225, 10 days, allows complete diffusion through the cell cluster, whereas this is not the case for bismuth 213, 47 minutes. Further, cell survival is 10 times lower for actinium-225. The RBE at 1% survival is 5, yet the internal targeted RBE for single cells and relative to betas and non-targeted alphas is 120. So why the difference? Simply that the range of the alphas is much smaller than for betas, such that targeted cancer cells receive a large fraction of the short-range alpha energy, but a very, very small fraction of the long-range beta energy. Monte Carlo calculations show that the ratio of specific energy S is 100 to 1,000 times the single cancer cell and endothelial cell irradiations. In vitro studies and calculations show that for high specific energy and short range, cells must be targeted. However, in vivo models are much more complex because of the accessibility of the conjugate to tumour cancer cells, cell clusters, and isolated cells in transit. Results are shown here for pancreatic, breast, and a prostate cancer for yttrium-90, lutetium-177, bismuth-213, and actinium-225. The effect of a single systemic injection of bismuth-213 C595 for pancreatic xenografts at 3 days post-cell inoculation is shown. Inhibition of tumour growth and mouse survival increases with the higher injected activities. The upper curve is tumour volume versus time. The lower curve is the fractional survival. C595 is a generic monoclonal antibody targeting MUC1 expressed by many different cancers. Now in A we have a local injection of 50 microcuries of bismuth-213 J591 or non-specific ARC at 2 days post-inoculation. In B we have an intralesional injection of 50 or 100 microcuries for a tumour volume of 40 to 60 cubic millimetres. And in C we have an intralesional injection of 50 or 100 microcuries at an initial volume of 70 to 80 cubic millimetres. Now these results show that the tumour regression is only observed for targeted therapy and a higher dose is needed for larger tumour volumes. In vivo comparison of prostate cancer therapies at the maximum tolerance dose is shown here. The bold line is the mean of measurements. In A, no significant difference in the rate of tumour growth between untreated controls and stable lutetium-175 is shown. In B, we have 2 doses of lutetium-177 in the upper and 4 in the lower. And in C, we have bismuth-213 in the upper curve and higher doses in the lower curve, and in D, we have bismuth-213 AMBA in the higher and lower doses. The beta emitter lutetium-177 does not control any tumours. Bismuth-213 achieves far greater efficacy and the higher dose gives the best control. AMBA shows better targeting than PESN. Comparison of 3 targeted approaches to control of in vivo prostate cancer are now reported. So immunochemical staining of receptors is given for 3 xenograft models and cell clusters. The vector receptors are 394 UPA, C595 MUC1 and BLCA38 again. While results are similar for PC3 cancers, this is not always the case for other cell lines than human prostate cancers. As such, multiple vectors would be indicated for improved efficacy. Now we now look at actinium-225, which shows marked superiority in this study with transgenic breast cancer mice compared with bismuth-213 and yttrium-90, which are only a little better than controls. Injected activities were at the maximum tolerance dose in each case. We're now in the final part of this presentation, when we examine the clinical evidence to determine the preferred radioimmunoconjugates. This includes antigen expression, positron emission tomography and SPECT imaging, and therapy with lutetium-177, bismuth-213 and actinium-225 to determine the optimum conjugate and protocol for the therapy of castrate-resistant prostate cancer. The C595 antibody targets MUC1 expressed by many different cancers. Results for prostate cancer expression are very favourable, especially for lymph node metastases, with a 60 and 90% expression. 86% of the MUC1 positive tumours were Gleason grade 7 or higher, and overexpression of MUC1 was found in later stage cancers. MUC1 is a tumour-associated antigen that is highly related to tumour progression. This antigen is ideal for targeted therapy to control micrometastases and hormone-refractory disease in prostate cancer and other cancers. So now we show images for PECT and SPECT for metastatic prostate cancer from left to right. PET images with gallium-68, PSMA ligand, F18, IMP, zirconium-91, J591, and SPECT for lutetium-177, J591. Biodistributions are different for each vector. Salivary gland uptake is high for the PSMA ligand, which is absent for J591, in which saliva uptake is high. The kidneys and salivary glands show the highest uptake of gallium-68, PSMA-617, at 3 hours post-injection. Mean tumour to background was very variable, at 20 plus or minus 17 at 1 hour, 38 plus or minus 39 at 3 hours. Gallium-68 high contrast shows lesions between 2 and 3 hours post-injection, but not so after therapy. A very nice result. Lutetium-177 beta therapy reduces PSA by a factor of 20, but complete cell kill is not achieved as PSA increases afterwards. We now show some comparative studies done at the maximum tolerance dose and dose fractions. 70 millicuries per metre squared with lutetium-177, 17.5 millicuries per millimetre squared with yttrium-90 J591. And you could ask why we normalised the body surface area. It's hardly appropriate for immunotherapy. Lean body mass would be better. Now for yttrium-90 we have 2 to 3 doses and giving thrombocytopenia increasing at the higher doses and after repeat treatments. Lutetium-177, there was no severe toxicity below 60 millicuries per metre squared. 2 doses of 45 or 60 millicuries per metre squared were toxic. 3 doses of 30 were well tolerated. Note the positive effect of fractionation for low LET radiation. Now 47 post-hormonal therapy patients received a single treatment of lutetium-177 J591 at 65 millicurie per metre squared. We had significant declines of PSA from high to low. Metastases targeting confirmed in 90-40% by planar imaging. Toxicity, 100% reversible hematologic toxicity. Thrombocytopenia without significant hemorrhage. So 26 grade 4 neutropenias and 1 episode of febrile neutropenia. So these results show that PSA declined and for longer survival, more grade 4 toxicity, but no serious non-hematologic toxicity occurred. A single dose was well tolerated with reversible myelosuppression, evidence of dose response in tumour targeting and PSA. However, the therapy was not curative. The Heidelberg TAT project for prostate cancer patients uses actinium-225 PSMA-617 ligand with pre and post PSMA imaging. 50 patients received 130 therapies. The results are reported to be impressive, with several patients achieving complete remission in the 2 years of the ongoing trial, some of whom had PSA values greater than 3,000 nanograms per mil. However, permanent damage to the salivary glands is reported for most patients. The choice of radioisotope is complex and rather arbitrary and depends on the actual target, that is isolated cells, cell clusters or tumour. We attempt to list the key parameters on a scale of 0 to 5 as such. So physics, bismuth, isolated cells, bismuth, cell clusters, lutetium, tumour, lutetium or bismuth, and clinical bismuth. And the winner is bismuth 213 with superior therapeutic gain. That is the dose to cancer cells divided by the dose to normal cells. There are three options for alpha therapy of prostate cancer: C595, PSMA-617 and J591. These are compared in terms of the vector alpha versus beta. J591 is preferred as it also targets tumour endothelial cells and not the salivary glands, as does PSMA-617. C595 is not in the running, as not been imaged in humans by PET inspect. Choice of lutetium-177 beta versus business-213 alpha is in favour of the latter. However, comparative tumour regression is uncertain. Choice of actinium-225 versus business-213 is in favour of actinium-225 because of a higher specific energy and lower cost. So that's where we are today. Thank you very much for your attention.